in a sponsored session by Lumira DX regarding the need for point-of-care testing for D-dimers. If we start with some brief introductions, I'm Dr Matthew Fay. I'm a GPSI in cardiology and the medical director of Lumira DX. Through this session, I hope to take you through the size of the problem that we have with VTE, problems in clinical assessment, pre-test probability scoring, before we get on to D-dimer, some information from Lumira DX about D-dimer, and then what we might want to do with D-dimer testing beyond the acute event. Of course, as I say, I'm the medical director of Lumira DX, and I have a few other affiliations, including the honour of being one of the trustees of Thrombosis UK. When we think about VTE, it's really important to think about the size of the problem. And of course, part of that is that classic presentation of sudden pleuritic chest pain, breathlessness, haemostasis that we associate with a pulmonary embolism is rarely the case in how it presents. And what is quite alarming is that 40% of those people who die from a PE, a VTE event, have actually seen their clinician in the preceding weeks. I think it's worthy of a short pause there to think of the magnitude of that problem. People are realizing that they are unwell. They are realizing their body isn't functioning as it should. And so they go to where they feel they should get help. And unfortunately, in 40% of cases of those people who are going to die, who are fated to have that pulmonary embolism, unfortunately, help is not forthcoming. And that is the absolute crux of our problem with VTE. Are we teaching our clinicians, our student doctors, our student nurses, our ED staff how to spot a pulmonary embolism or a DVT? Are we educating people in the right way to ensure that this significant problem is actually in the forefront of their mind when they're seeing people? And that leads us to the question, how can we change this? How can we find those people who are suffering with the early symptoms of venous thromboembolism? They may have had a small shower of emboli. They may just have a DVT at this point. How do we find them? And the answer to this, of course, is that you've got to consider that somebody has a VTE event. So it has to be in your consciousness, and you have to have brought it forward. Saying that we can do test X and Y, as we'll discuss later in this presentation, doesn't improve identification if you didn't think to do that test in the first place. You can only spot a VTE event if you've considered that the patient might have a VTE event. So let's look at some of the evidence around this. And we're going to start with Emperor, if that's acceptable. Now, Emperor used registry data from the States to look at how ED dealt with severe pulmonary embolism and ensured that they were identified and anticoagulated appropriately. And what Emperor tells us is that if a patient was thought to have a VTE event, if they were thought to have had a PE, then the management was actually quite good. So people would get the appropriate investigation and they would get anticoagulated appropriately. However, it also highlighted that it was actually quite chaotic within the ED department in the way that people could be identified. And there was no real standardized approach when it came to pulmonary embolism. And that may be part of our problem. We've not got such a standardized approach. And it's easy, of course, at that point to say, well, this is healthcare. and it can be chaotic. But when we consider that in the view of another life-threatening situation, such as cardiac disease and coronary disease, what do we see in that situation? And of course, the first thing that we can comment on is very detailed and well-constructed pathways. So this is just taken from one of the hospitals in the UK, the North Bristol, downloaded from the web. And you can see the nice guidance, the national guidance has been distilled into a clear flow chart, telling people how to consider those who have clearly had an infarct with the classic changes on the ECG, those people where you think they may be having an infarct, you may want to be using your troponin tests and so on, and those where you feel that they're low risk, but still consider the possibility. So even in the low risk patients, they're still considering the possibility that this could be cardiac disease, and they're processing and analysing accordingly. Now, cardiac chest pain, and I would say this as a man who spent many years as a GPSI in cardiology, cardiac chest pain is relatively easy to spot. NICE actually tells us the symptoms, and it describes 3 main symptoms that somebody with angina may have. And it tells us how relevant they might be. So we see the adverts with the tight belt across the chest, or the new ones with the hands crushing into the chest on the national awareness campaigns for chest pain. And we know that if we see all 3 of those symptoms, then this is likely to be a cardiac event. And if actually we only see one of those symptoms in an atypical setting, then it's unlikely that we're talking about angina. Now let's compare that to pulmonary embolism. And what we see is that those symptoms are less consistent. So in people who have been confirmed to have a pulmonary embolism, 50%, only 1 in 2 of them presented with that breathlessness that we're taught will always be there. Only 40% of them may actually have pleuritic chest pain. Of those who didn't have a pulmonary embolism, 30% can have pleuritic chest pain. Cough is very common. Cough is an incredibly common presenting feature in medicine in general, and is there in about 1/5 of cases. So we have these symptoms which are a little bit bland, and we're trying to get the clinician to say, well, think about it. Think that this might be a pulmonary embolism. Think that this might be one of that 40% if we don't act. So this is where we then think of DVT. Of course, the pre-runner for many people of PE. If we don't spot the DVT and we don't appropriately intervene with the DVT, then in many people this is going to progress. And what we find is that the symptoms with the highest sensitivity are calf pain and tenderness. So when I talk to my clinicians in general practice, they will tell me that a DVT is when you've got a swollen hot leg. And of course that's true in some cases, but when somebody presents with unilateral calf pain, with no exercise, no history, why have they got pain? Is it adequate to just say, well, I think you've pulled a muscle? Or maybe there's something else that we should be thinking about. Maybe there's something else that we should be doing here. And we'll talk a little bit about how we might want to do risk stratification in a short while. So let's say we've got beyond step 1 and we've actually got the clinician thinking that this could be a VTE event. What we then need to do is think, what is the next investigation? Now, for our colleagues in ED, they can arrange a chest x-ray and that will be done in the department. For those of us in general practice, of course, this is going to be an appointment some days away and the patient will have to go to the hospital. And then that x-ray needs to be looked at by somebody who really knows how to look at chest x-rays, because the changes can be subtle And actually, in the vast majority of people in the early stages, the chest X-ray is actually completely normal. So the chest X-ray is not going to help us very much. Let's think of a point of care test that we have in general practice. So many GP practices nowadays have the ECG. So maybe we can get an ECG on the day. And of course, what we're looking for is this classic, and every cardiac interested clinician has one of these in their collection. And of course, this is the classic S1, Q3, T3 of the severe right heart strain, of the pulmonary embolism. And of course, the other thing you might see is right bundle branch block, again demonstrating that severe right heart strain. Remembering, of course, that right bundle branch block is a variant within 5% of the population. So you may see it and miss it because you think it's a variant. But we don't see this very often. This patient would be unwell because they've got severe right heart strain due to a large embolism. What's the most likely thing you're going to find? Well, you could have taken the pulse and found it. The most likely thing, the abnormality on the ECG you're going to find is a sinus tachycardia. And of course, the patient's in pain. And the patient's worried about what's going on. So maybe they've just got a sinus tachycardia. So this doesn't really help us much. And again, our problem is that actually, in the vast majority of people presenting to us in general practice who may have lesser symptoms, the ECG is probably completely normal. We haven't got to that point where the circulatory collapse is occurring, because those people tend to end up in hospital. So we've got somebody with these vague symptoms and an ECG which is normal, and we're reassured, or should we be reassured? So the next thing, once we've thought this might be VTE, I would suggest the next thing we need to do is not necessarily leap at tests, but to start thinking about whether or not this could be a VTE event. And the way that we can do that is to consider the risk factors. So if we take ourselves through the risk score, what we find is that there's many of these points that will help us work out who might have a VTE event. Of course, in DVT, we have that slight fiddle factor in the fact that if I really don't want it to be a DVT, I can remove 2 points from the score. Although the larger the score, the less likely it is, I suspect, that I will want to remove those 2 points. But if I really don't think it is a DVT, then I can take 2 points away, which could significantly lower the score to a low risk setting. Or when we consider PE, of course, I add 3 points if I think that the diagnosis is going to be a PE. And since a positive test is 4 points, and I only need to score one more item before they would hit the criteria for further assessment. So if we think about that, if we actually process that when we're seeing our patients with those symptoms we can't quite nail down, that might help us start to select patients who need further attention and consideration of VTE. Another score that we're hearing a lot about, of course, in PE is the PERC score, which again helps us grade the criteria. And so we have a few more points that we can score in the PERC score. So that tachycardia that we've already discussed is there. And this helps us grade the risk of somebody, with the chances that somebody's going to have a PE. However, we need to think about the PERC score in a little bit more detail, because what Prosper tells us is that the PERC score is very useful in those people who have an otherwise low risk of having a VTE event. So essentially, we should be using the PERC score after we've used something like the Wells score. If the Wells score is very high, then we should be thinking that, well, this is a PE and we should move on. So the PERC score is useful, but it needs to go in its place, which would be further stratification. So within the GP group that I worked with, we tried to look at a way that we may be able to increase the people who are getting screened for PE. Try and make it so that we stop missing these people. Start making it so that when somebody is returned back to our care and they've had a confirmed VTE event, maybe we should be doing some root cause analysis and having a look back at ourselves, make sure this patient wasn't under our care prior to that event, and make sure that if they were, we learn lessons. So one of the things that we talked about in the group of clinicians is that we need to think about VT. Just as I've said, if you don't think of the diagnosis, you won't start the pathway. If you've thought of the diagnosis and the patient pregnant, then you need to arrange for them to be seen at the hospital. And all our role in general practice is finished, and they should move on to that hospital-based care. Then do a Wells assessment for everybody else. And if they score high, then we know that they need to be assessed. So that means they are either going to be referred up to the hospital if we're thinking it's a PE, or if it's a DVT within the Bradford area, we would give them a DOAC while we arrange the scanning. Now, if it's low risk, but you've thought about it, in that situation, we were looking at the idea that we'd arrange a D-dimer, and we'd do that in the practice with a point of care kit. And if that was positive, of course, that would drive us back up into the pathway for DVT assessment. If that was negative, we need to think of another diagnosis. And so you can see how we can build, almost like that cardiac chest pain pathway, a pathway which can work. But is this as good as we can get? And of course, we can continue to look at the evidence. And so we could go to years. So years is a way of looking at pulmonary embolism using a clinical assessment and holding D-dimer in the centre of the assessment. And what the years approach showed was that you can actually reduce the amount of CTPA, which is going to be important. If we're going to be driving more people trying to find that missing cohort in general practice and ED, that means more suspicion is going to be raised, and therefore more people are going to come through needing testing. So we need to make sure that we've got systems in place that could deal with that. And I'm sure many are aware of the years system. So you've got the clinical signs of a DVT or haemostasis, or the fact that you personally think a pulmonary embolism is very likely. Now, if you get none of those points and you do a D-dimer and that's less than 1,000, then we can say that it's unlikely to be a PE. So on clinical suspicion and a negative D-dimer and no other signs, then this could be a reassurance. If the D-dimer is greater than 1,000, then they need to be assessed for PE. Similarly, if they've got a year's score of 1 or more, and the D-dimer is greater than 500, then that would be the point where we would consider a CTPA. So this is using D-dimer as a way to try and adjust who might get further investigation with our gold standard, which is the CTPA. But is that all we can say about D-dimer in this assessment? And of course, here we can go to adjust PE. Now, what adjust PE was looking at was if we have a cutoff of 500 units, as we see in many of the papers, could we look at that in a bit more detail? We know there are other things which adjust the can affect the D-dimer results, and one of those significant points, of course, is age. So what adjust PE looked at was the idea that we could adjust the D-dimer. So we're not just going to use a cutoff of 500 for all ages. And what adjust PE suggests is that if we have a D-dimer of 500 in those under the age of 50, well, that would be positive. Once you break through that threshold of 50 years of age, our D-dimer cutoff will be your age times 10. So if you're 60, that would be a cutoff of 600 units. So this allows us to try and refine yet further those people who we're going to refer through for the more complex testing. So if we go back to our pathway, this would be saying that when we say a negative D-dimer, what we're actually saying is that that's now age adjusted. So in the under 50s, 500, in the over 50s, 10 times the age. And this again will reduce the number of people who need to have initial scans and further scanning in line with the NICE guidance. So I've mentioned NICE there. So what does NICE say about all this? So for those of you not from England, NICE is our National Institute of Clinical and Care Excellence, and they define our pathways of care. They're not mandated, but they're strongly recommended. And they look at the evidence and they tell us what we should be thinking about. Now, unfortunately, missed by many was that the NICE guidance for VTE was updated in 2020 and came out in early March, just before the country went down into lockdown for the coronavirus pandemic. But what we find in the guidance is that it does like D-dimer testing. So what it's saying is that people who are unlikely to have a VTE event, so those people who have done our Wells score, and that score shows a score of 1 or lower, that it doesn't mean we should just dismiss these people. We shouldn't say that's it. What we should be doing is that we should be using a D-dimer to determine whether our clinical suspicion is correct. And what it specifically says is that if we're not going to be able to get that D-dimer in a timely manner within 4 hours, then actually we should arrange for anticoagulation or anticoagulation in some form. It also uses the D-dimer again, so that in those people who have a positive D-dimer and a positive Wells score, so these people are high risk, when they have their initial proximal leg scan, if that's negative, then you should look to the D-dimer. If the D-dimer is positive, so we have a positive Wells score, a negative initial scan, but a positive D-dimer, that person should have their anticoagulation discontinued and then rescanned a week or so later. And only then, if they've had 2 negative scans, would they be discharged from the pathway. Similarly, what they say is in those people where that gut feeling is that they have a pulmonary embolism, and you do the Wells score and that score's less than 4, then again, they're suggesting that in that group where you considered it, you would actually do a D-dimer. And again, that D-dimer should, if that's going to be delayed by over 4 hours, then an anticoagulant should be provided until the result of the test is received. So this is going to have patients who are relatively low risk being anticoagulated while we're waiting for a test result. And I would suspect there is a significant group of us clinicians who are a little bit uncertain about this idea of anticoagulating low-risk patients. So what does NICE say about that? And NICE actually says, well, maybe we should be thinking about doing a D-dimer point of care test so that we can get that result quicker. And hopefully, I would suspect that means that they were hoping that people may suspect and consider VTE that bit more, because there's not that risk for the clinician of prescribing a medication that potentially could cause harm in a relatively low risk patient. Now, the first thing that anybody's going to say is, well, point of care is expensive compared to lab testing and the NHS has no money. Well, NICE did look at that. And actually, what NICE looked at when it looked at the whole pathway cost of using a point of care test in VTE management, actually, they found that it was cost effective in DVT, and they found that it was cost effective when we considered pulmonary embolism as well. So NICE are actually advocating the use of point of care testing for D-dimer in VTE And that's there in their guideline as published in 2020. So this is why Lumira DX is sponsoring this session. We have a platform which can undertake D-dimer and other tests, and we'll get onto those, that can do it in a timely manner, so the results available within 6 minutes, and it can connect through to the clinical record, so it can deposit this in the electronic health record as well. The test is easy to perform. The platform uses its little card, and all of these are the same, irrespective of the test that you might want to do. So the technique is exactly the same if you're doing D-dimer or CRP or NT Pro. So the test itself is relatively simple, and the accuracy, as we will see, is similar to the lab. These tests are state-of-the-art. They're printed in their thousands. As with many of our point-of-care testing companies, Lumira pivoted to assist in the COVID pandemic. And so for a short while, we've been producing a great number of COVID tests to ensure that people could test appropriately and isolate to try and help with the COVID issues. However, we're beyond that COVID period or that high intensity COVID testing, and it's time for Lumira to get back to doing what it wants to do, which is to change patient care and the pathways of patient care by ensuring that people have quick access to diagnostics. And as you can see from this slide, we have several tests already available, and there's more coming in the future. Now, quite rightly, people will always want to know, well, if we're producing a point of care test, how does this compare to the lab tests? Because as a clinician, I don't want a point of care test which is convenient for me and the patient, but is not as higher quality as sending the test off to the lab. And so, as you would expect, our assay has been assessed against the VDAS and other lab-based systems to ensure that we have exactly the same quality of results as you would get from a lab-based diagnostic. We did have a look at the evidence to say, well, how is D-dimer being used in primary care? I've been a GP for over 20 years, and we use some point of care testing. I can't say that we use a lot of D-dimer point of care testing, but when we reviewed the literature, we find there's not much written, but what is written is all actually very pro the idea that we should be testing D-dimer in primary care. So we have an evidence base to support us in that we should be testing for D-dimer early. We should be testing for D-dimer using point of care because NICE tells us that that's cost effective. We have a device here which has the same specification and quality of result as the lab-based results, and we're yet to see it truly implemented and put into pathways of care, but that doesn't mean it shouldn't be. Just to move on from the device, this is a study using the Lumira device. And I'm very grateful to Professor Rick Brody for these slides. He was a principal investigator on EMBOL-1, and I'm very kind of him to allow me to use his slides. So what EMBOL-1 was looking at was the diagnostic challenge of VTE in the ED. So this is in the, not in primary care, this is in the ED department. And what we're looking at was, we're looking at how point of care D-dimer as provided by the Lumira platform compared with lab-based care and standard of care. So we have, as we've already discussed, the vague symptoms that tend to present as VTE. And then we do pre-test probability to try and work out who we should be assessing in more detail. And as we've already highlighted, D-dimer pops up into many of the pathways. So we have the platform, which we have previously said has a high quality D-dimer assay. But what we've managed to elude from EMBOL-1 was that actually, if you have a low pre-test probability of PE or DVT, and then a negative assay on the Lumira machine, then we can exclude DVT and PE with no further testing. So it was a prospective study. We were taking samples of both venous and capillary blood and plasma, and we're using the VDAS machine as well as comparing that to the Lumira machine. We had multiple sites, both in the UK and in Germany. The indication to get you in was the patient had to be over 18. They had to be able to consent, obviously. And they had symptoms and signs suggestive of a thrombotic event. Clearly, we had exclusion criteria, those things which are well known to affect the D-dimer result. Of course, if somebody's anticoagulated, it would make the D-dimer hard to read. End of life issues, of course, and pregnancy, because pregnancy makes the D-dimer unreadable, really. So patient self-presents to the ED. They're assessed with a pre-test probability, and our initial aim was to get 1,000 people into the study. We would give the patient information. We'd take the samples, which included samples which are used in the acute care, but also Lumira would take tubes to do quality control on at the reference lab using the VDAS and Lumira device. And then we follow patients up to 90 days. So we use the Wells score for DVT and for pulmonary embolism, and we've already discussed those. So one of the things we have to say is that we wanted 1,000 patients, and this was caught up in the COVID pandemic. So unfortunately, that has reduced the number of patients we managed to get included. So we managed to get 684, of which 616 met all the eligibility criteria and were included in the study. When we're looking at the analysis, we're using a cutoff, as with many of the studies, saying that 500 is below 500 is negative, and above 500 is positive. So we didn't use age-adjusted D-dimer, although that would be something we could consider in the future, but we didn't in this study. And then we made sure that the results were eligible and they were valid, and so they were appropriately assessed. And out of the patients, what we found is that we have perfect alignment with the VDAS. So we find that the results are completely comparable. And what we also find is that those people with a D-dimer of less than 500 units as a cutoff could be safely excluded. So at 100% sensitivity and 100% negative predictive value on all the matrices, we find that we can say that we can exclude a DVT or a PE event. When we compare ourselves to the VDAS machine analyzer, what we find is that we match in sensitivity, specificity, and negative predictive and positive predictive values. So we're completely in line with the industry standard, and it allows for that quick testing of somebody. So we're now in a situation where somebody could present at the front door of ED and be triaged into a DVT pathway, a non-DVT VTE pathway, just by a simple single drop of blood on the platform. So the EMBOL study has demonstrated that we've got 100% negative predictive value for those people with a low pre-test probability, and that we have the same statistical results as the VDAS to exclude VTE. We'll be publishing that at the end of the month. So is that the end of D-dimer? Is that all we can say about D-dimer? And of course, VTE doesn't stop with the acute diagnosis and the period of acute anticoagulation. We have patients who have clearly a trigger for their VTE event. They may have had a recent surgery. They may have been acutely unwell in hospital for some time. And we know that they probably can discontinue their anticoagulation after a period of treatment. But what about those people who walk in who have no previous history to suggest there's no situation which has caused the VTE event? And maybe D-dimer can help when we look at that. And so we do have studies looking at the duration of treatment and using D-dimer to assist. Now, what we have is the comment that in men, because their risk is actually so high to develop a VTE event within the following 5 years, it's a 20% risk over 5 years if you have no provoking feature, then actually D-dimer doesn't particularly assist in working out who may need ongoing treatment. And actually, the advice would be that most of these people, after consultation, of course, and discussion with the patient, probably require long-term anticoagulation. However, what we do have from the White's paper is that in women where the risk is lower, then a positive D-dimer after a month off therapy might actually be a way of assisting us in having that conversation with the patient. And if somebody has a negative D-dimer a month after treatment, then they're low risk and we could stop the anticoagulation. If after a month off treatment, we find that the D-dimer is still elevated in somebody who has no obvious triggering feature for their VTE event, then this is somebody we may want to have a conversation about ongoing treatment, because that will mitigate the risk. And we all have seen the data around ongoing anticoagulation to reduce the risk of VTE. Does D-dimer have any other roles? Well, what about cancer patients? So cancer patients are very high risk of VTE, as you can see from the previous risk scoring. So we know that cancer patients do have a high risk of VTE. And of course, it seems that we should be trying to look at that risk, particularly when you consider the risk for the patient, but also the cost that's being put into the management of somebody with cancer to then allow them to suffer a VTE event. So can D-dimer assist in that? And the answer to that is it can assist in helping us work out who we should be a bit more aggressive in VTE prevention. So this isn't treatment level of anticoagulation, but this is preventative measures in those people who are diagnosed with cancer on active treatment. What we could also consider, of course, is that other cohort of patients who we know have a high risk, who've had intensive medical treatment for some time. So they've been in hospital for some weeks, been clinically very unwell, which required their long hospital stay, and then they're discharged back into the community. But we know that they have an elevated VTE risk for up to 3 months. And so again, how can we work out who we may want to risk stratify and ask them to take antithrombotic measures? And again, the D-dimer has been shown to assist in that. And of course, if we're going to consider that group of patients, then we also know that we do have a 10A inhibitor, betrixaban, which has been shown to reduce the VTE risk without increasing bleeding risk in that cohort of patients. So looking at them in a bit more detail may be of value when we're considering how we may want to treat into the future. Any other uses? So I've spent a long period of my life very involved in the AF pathways, and could D-dimer help us in AF? To move away from the Chad's Vasc and find other ways of risk stratifying those people with VTE, and the answer with AF, and the answer to that is it doesn't seem very helpful. It doesn't add much value on top of the assessments that we're already doing. Although we know D-dimer is elevated in AF, and it reduces when the anticoagulants are started to reduce that risk of cardioembolic stroke. It doesn't select patients that would not have already been selected using the Chad's Vasc scheme and the standard of care. Again, in that coronary realm, do we have any evidence that in coronary disease that we could use D-dimer to help us assess where to put our attention? And again, the answer is no. So we have D-dimer in its place with VTE, and we need to make sure that we continue to study it in that area to see if we can refine its value. But as yet, in other cardiac conditions, it seems to be of less use. Just briefly, I did mention that the platform has multiple other investigations. So INR has been established on the platform for some time now, but this year we've released the CRP and the MT Pro and HbA1c. So there are more tests coming to this platform. And as I've suggested earlier, those tests are all performed in the same way. So this isn't multiple machines at the practice and multiple different ways that the clinicians have to learn how to use it. This is one machine, one method. And maybe we can look at how we can use that. So if we're to look at those patients with COPD who use a lot of resource within primary care during the winter months, and unfortunately, quite a lot of antibiotics, maybe we can address the antimicrobial use using point of care CRP. And we know from studies in Cardiff that using a point of care CRP can actually reduce antimicrobial prescribing in COPD by up to 20%. And when you consider the amount of antibiotic that this group of patients require, and during the winter, 20% is not an insignificant number of prescriptions. What we need to do, of course, is make sure that this is done safely through structured pathways and education. So the platform isn't just about D-dimer. It isn't just about trying to improve access for patients who may have VTE. We can use this platform for multiple other tests within general practice, and more tests will come into the future. I'm very grateful for your attention, but just to summarize, VTE is a significant problem, and one of the biggest problems is that we keep missing it. So we need to really drive into the education of our clinicians at the front doors of healthcare, in primary care and in the ED, to say, think of VTE, think maybe of doing a risk assessment on somebody when you can't put the symptoms together and you can't make it make sense. It needs to maintain that discussion, because we all know that a new program tends to fade after a few weeks. So we need to keep that conversation going about getting the diagnosis and thinking of risk score. Point of care, D-dimer will assist in making a prompt diagnosis, particularly outside that hospital environment, trying to keep that workload away from the doors of our overpressured emergency departments. As always, really important to keep the pathway simple. Try and keep the intervention as simple as possible, and the DOACs have made that much easier when we're talking about VTE. Try and keep the tests close and convenient for the patient, and ensure the patient knows what's happening to them. Education of the patient is always vital. Information for the patient, always vital. So thank you very much for your attention. I've been Dr. Matthew Fay. I'm the Medical Director of Lumira DX, and feel free to contact me for any information or follow me on Twitter. Thank you very much.